Burns. Burn injuries can cause two types of shock. This can be hypovolemic shock, but technically in this chapter, it's called burn shock. But in all respects, it's actually hypovolemic shock. However, since this patients, the patients with burns also suffer from acute lung injury, directly and indirectly. This can also lead to a distributive type of shock, okay? Because there will be vasodilation here as well. So it's kind of going to be overlapping. But either way, the patient's blood pressure here will drop because the patient will experience hypovolemic shock. And the complications, there are two complications that can result here. One is DIC as well as ARDS. ARDS will be discussed later under module 6. Okay, we will not discuss that in this chapter. Generally speaking, burn injuries are preventable. So fires are preventable. So one of the questions on the exam and on the NCLEX will be how to prevent fires. Okay. There's a paragraph on that here. Here's prevention. One graduate mentioned that they got that he got a burn prevention question on the NCLEX, and it was all about the number and location of smoke detectors and CO detectors in the home. Some of the or most of these burn prevention interventions are really self-explanatory as well as practical. Okay, you just read through. I hope you have the common sense to prevent fires. Okay, for instance, water temperature. It's winter, we use hot water a lot. Smoking. My father almost burned our house down one time, and I was 9 years old. He was smoking in bed. When we were playing outside and we saw our house was up in smoke coming out of his room. When we got there, we thought he was toast because his bed was on fire. And later we found him on the next bed sleeping. I don't know. Who knows? Okay. So like I said, these are common sense. But some people don't have any. Um, I remember seeing on the news one time when there was a hack in one of the pipelines on the East Coast, and people in Florida, of course, they were anticipating that fuel prices would go up because there will be a shortage of fuel, which it did for 1 to 2 days maybe, and people panicked, right? So people were filling non, um, uh, I mean, anything they could put fuel into, including plastic bags. You know, shopping bags? Yeah, they were putting fuel in plastic bags and just tying them up. So, like I said, some people do not have any common sense. Let's start with severity because there are many types of burns. So, severity can be determined by four factors. One is the extent. When we say extent, we mean how many layers of tissue were burned. meaning how deep is the burn injury. Second would be how much surface of the skin was burned. So we will use the basic formula of the rule of nines to calculate TBSA, or total body surface area burned. Number three is the location of the burn. Which part of the body was burned? Obviously, burns in the upper chest, neck, face would mean there is inhalation injuries, correct? Meaning the patient inhaled either smoke, fumes, or the actual flames, correct? And therefore it will close the airway. So that would be most dangerous location. And then number four would be the patient's comorbidities. It'll be different if it's a young person, let's say Kayla or Musavir or Natalie will be burned. Okay, I assume they have no chronic illnesses, but it'll be different if it's a 78-year-old diabetic with heart failure and kidney disease who gets burned. That's a different story altogether. Yeah. Okay. So those are the four factors. One is that will determine the severity. One is the depth, how deep, how many surface area, how many surface of the tissues of the skin were burned. Second is the body surface area, TBSA. And third is the location. And then finally, patient's comorbidities. As far as age goes, the very young and the very old are both at risk. Very young because the babies, especially, are mostly water, correct? And give me four functions of the skin. What do we need the skin for? One, protection. What's another? Thermoregulation. Does it keep the fluids and electrolytes together in the body? Yes. And finally, we have vitamin D synthesis, yeah? And then also, number five would be our identity, yeah, for aesthetic purposes, our beauty. Okay, so we owe all that to our skin. But the most life-threatening functions, which are now absent after a burn injury, of course, will be protection, thermoregulation, and fluid regulation. So therefore, if the very young and very old, you can imagine the extremes, right? So a very young person who gets burned, again, very young people are mostly water. So without skin, water will evaporate. Okay, so they will die, more likely to die. And the very old, obviously, very wrinkly skin, already have poor skin turgor to begin with, plus chronic conditions are present in the elderly, so they will have higher mortality as well. Let's start with the depth. We have a table. However, on the exam, I will grab the test options both from the table 57-1 as well as in the paragraphs that follow. The American Burn Association no longer use first, second, third, or fourth degree burns. We now use the by tissue layers. Okay. By thickness, sorry. The official term is thickness. So first degree, also called superficial burns. These are the characteristics. The summary again is in the table 57-1. Then we have second degree, which is now called partial thickness burns. Good thing with your textbook is they only have 4 burn depths. Other textbooks have 6 because they have, let's say on second degree can be superficial partial thickness, or it could also be deep partial thickness. Okay. But I believe your textbook only has 4. Here they are. Table 57-1, superficial. Examples are sunburn, or let's say you spill hot water or hot coffee on your skin, on yourself. And these are the characteristics. And this is the wound appearance. Appears red, blanches with pressure, or it could be dry, and there will be blisters. Yeah, that's what sunburns look like. So I'm testing only the appearance. I'm not really going to ask you anything about how long it will heal. It will just be recognizing and identifying the depth, right? As simple as that. Of course, for you to remember the appearance, it would help if you know which layer of the skin was involved, meaning if it's only the epidermis. So, of course, are there any blood vessels involved here? No. So this will heal pretty much fast, right? Just a week or two, maybe or even a few days. And of course, it will help you see what will the appearance be. So of course, if you burn the epidermis, then the epidermis is basically dead tissue layers, correct? They will separate. Once it separates from the dermis, then you'll have a blister there. Blister, of course, will be fluid filled. And because blood supply is intact, it will appear red. Let's go now to the deeper injury. Partial thickness now. So yes, it burned off the epidermis and it also burned the portion of the dermis, the living layer of skin. And here are examples of these burns. So what will it look like? Definitely lots of blisters. Mottled red blaze, disrupted, the epidermis is gone, then it will appear wet. Okay, because there's no more epidermis is gone. Dermis is exposed, so that's why it appears moist. It's wet, it's red, very painful. And there will be plenty of edema because the blood vessels are underneath the dermal layer. So therefore, there will be a lot of uh, vasodilation causing edema. Plus, there will be capillary membrane permeability here. So that's why the capillaries become leaky. That's why it appears wet. Next, full thickness now. And these are the causes. And then of course, you lost the epidermis. The dermis is also gone. Now the subcutaneous tissue has been burned. So without the epidermis and the dermis, what will the wound look like? Dry, pale, white. Why? The blood vessels in the dermis were burned off. Okay, so now it looks pale and white. Can also be leathery. What does leathery mean? What does leather feel like? Soft or hard? It's hard. So the skin is now very hard to the touch. Can also be charred, meaning it can look black. Okay. Coagulated blood vessels. So that's why the blood vessels were burned off. So does it still appear red? No more. So there'll be eschar. Eschar is dead tissue. Okay. So the eschar can be yellow, can be black or brown. And finally, fourth degree burns. You lost all surface tissues. You burned through the epidermis, the dermis, the subq. Now you have muscle and bone exposed. So the wound will appear charred. What does charred mean? When you left the barbecue on for too long, and now your chicken or your turkey is all black. I can do the descriptions or I can also use pictures. There are pictures on page 1868. I can paste that on the test question. So this is what I mean by the paragraphs that follow also contain detailed descriptions of the burn area. Okay, so I can use combination of the table 57-1 as also the paragraphs that follow. Any questions on burn depth? Very good. Let's go now to TBSA or total body surface area burn. There are many rules to follow. However, for beginners, since we are not expected to work in a specialty burn unit, specialty burn units will use very specific measurements, measurement tools, including the Lund and Browder method. There's also the Palmar method. Palmer, sorry, is literally using the palm to measure the burned area. Lund-Browder method cuts the human body into very specific sections, and they will assign numbers to those cut sections, which makes it very, very detailed and specific and hard to memorize. So for us, it will just be the rule of nines, which is very simple to use. Also not very accurate. So the rule of nines is more of an estimate of the TBSA rather than a detailed calculation of the burn area. Here's rule of nines. So every some body parts will be 9. I'll come back to this chart shortly. So here is the rule of nines. So the head is 2 nines, 9 on each side of the face. So 9 face, 9 on the back of the head. No, sorry. I'm sorry. Erase that. Let me start over. The whole head is 9. That means 4.5 for the face, 4.5 for the back of the head. Is that understood? Okay, so the whole head is 9. Each arm is also 9. 4.5 on each side. Anterior arm, 4.5. Posterior arm, 4.5. The torso is quite big, so it's 2 nines. That's 18. So it's 18 in the front, 18 in the back. Each leg are also 2 nines. 9 on the anterior leg, 9 on the posterior leg. And because that's 11 nines, correct? That's 1, sorry. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Yeah, 11 nines. So that's 99. To complete the 100% would be the perineum. The perineum, therefore, will start from anything in the vulva, in the perineum. So you've got the penis, the scrotum, and then for the vagina also, and the rectum. Okay, that will all be just 1%. This chart is not really testable. This chart just tells you when a patient can be referred to a specialty burn center, meaning patients who sustain burn areas in these locations and in this extent will go to the specialty burn centers. Now, not all hospitals has a burn unit. Nassau County, yeah, they have a burn unit. New York Presbyterian does. Bellevue does. Okay, meaning what I'm saying is not every hospital has a burn unit. Does that make sense? However, every burn patient can be taken to any hospital, in any ER actually, for emergency care, because not all burn patients are near those trauma hospitals. So therefore, we have to take him to the nearest ER just to stabilize the patient. Otherwise, the patient will die from shock. Every ER is capable of treating shock. However, they cannot or are not qualified to treat the burns, however. So as soon as the patient is stabilized, then they will be transferred, even airlifted to a burn unit facility. Does that make sense? Okay, but patients have to be stabilized first. We save their lives first. We put in a central line, give them fluids or whatever is needed, vasopressors in order to treat the hypovolemic shock. And as soon as the patient is hemodynamically stable, then they're transferred immediately to a burn center for continued specialty care for the burn injuries. Does that make sense? Okay. So who are these people that will be transferred? Partial thickness, 10% or more TBSA. Remember the location I mentioned earlier? So what's wrong with these locations here? The face, the hands, feet, genitalia, perineum, or major joints. What is the importance of these locations? Meaning, why do we need these parts of the body? Face, not really for your looks, but for the airway, correct? So we have a facial burn. That means, is there any inhalation burns? Guaranteed there is. Because have you ever seen a person who's scared that will exhale? Like when you scare somebody, will they go or will they go? Yeah, okay. So everybody gasp, okay, as an instinct to something scary. Is fire fun? Being burned fun? Or is it the most scary thing you've ever experienced? Yeah, when you're in fire, that's scary. So you will tend to gasp and then you inhale the fumes, the flames, the smoke. Hands and feet. What do you need hands and feet for? Can you do anything without your hands and feet? No, you're less than an animal, right? So what differentiates us from other mammals? Our thumb, correct? Okay, so if you lose the use of your hands and feet, you can't do anything. Okay, although we see, Paralympics with no arms and legs, but these are extraordinary people, however. Genitalia and perineum, what do we need those for? Is it important to you? Yes, I'll leave you to whatever you were thinking, if it's for sexual pleasure or for reproduction or for elimination, for instance. Okay, so whatever you were thinking. And major joints, same thing, just as important as our hands and feet. Yeah. Okay, so if you have any of these injuries, third-degree burns, electrical burns, all the way here, for rehab, they all go to a specialty burn unit. All right, let's see what happens when we experience or sustain a burn injury. So the skin is the largest organ of the body. It provides protection, provides thermoregulation, keeps all fluids inside the body. So therefore, when the skin is damaged, what happens to all those functions I mentioned? Gone. Okay. So there's no protection. You're at risk for infection. You cannot control your body temperature. You cannot keep fluids inside your body. By the way, the burn injury we're talking about here are, of course, major burns. When you burn yourself, let's say spilled coffee on your finger, or let's say you touched um, a hot handle, for instance, or let's say um, you were wearing shorts when you're riding your boyfriend's motorcycle and you hit the exhaust pipe, for instance. Okay, so we're not talking about those. Those are minor burns. Okay, so here we're talking about serious ones. Are we clear? Okay, meaning there is 10% or more of your body TBSA burn. That's a serious burn. Exceptions are, of course, any burn in your eyes, hands, eyes, in your face. Of course, those are serious burns. Yeah. Okay. No, regardless of the depth. So any injury to the eye, is that always serious? Yes, there are a few exceptions, but the rule is about 10%. So if you sustain 10% or more of your body that was burned, then that's considered serious. All right. So what happens to the skin is here in the depends on the tissue layers, but beyond the injury though, especially the blood vessels around the site of injury, they are the first ones that will have localized capillary membrane permeability, increase in capillary membrane permeability. Just like your pimple, for instance, once you pop a pimple, it bleeds and then stops bleeding, and then there's liquid that will come out, right? And it gets swollen. So same exact injury here. So the injured capillaries around the area will start leaking. Okay, so all the blood vessels around there will start leaking fluid. At first, it will be localized, meaning it will only leak around here, whichever capillaries were actually injured in and around injured area will leak. However, if the patient sustains a major injury, this capillary leak will extend beyond the site of injury, meaning even if only one arm, the whole arm was burned, in the next 24 to 48 hours, the patient's whole body will have uh, edema, meaning the swelling will go beyond the site of the burn injury. Okay, so that is the most crucial part. So we'll talk about the phases of the burn injury, as well as our goals and interventions during each phase. So the crucial part here is really the not only the circulation, but the systemic body response that will follow the burn injury. You should already understand how the airway, okay, so airway, once burned, of course, will have edema. It will swell, therefore, the airway will close, right? So our rule here in treating burn injuries will be we intubate early because we know that right now, yes, the airway is still open, but will it stay open over the next 24 to 48 hours? Will the swelling go down immediately? No, the swelling will actually get worse over the next 2 days. So therefore, we will intubate early rather than waiting later wherein we cannot insert a laryngoscope anymore. Do you understand? So the release of local mediators is responsible for the capillary leak. So the blood vessels become very permeable, start leaking fluid. Therefore, the patient is losing fluid. So we can conclude that in burn injuries, there are two ways the patient loses fluid. One is absolute, meaning when I lose this skin here because I burned it, can I keep water in this area of my body? No, water will evaporate. However, there's also a relative fluid loss, meaning once the capillaries become very leaky and start leaking fluid, did that fluid really evaporate or get stuck in between the interstitial spaces? It got stuck. Okay, so we call that edema or third spacing. So meaning you lost water two ways, absolutely as well as relatively, because the fluid in between your tissues, meaning this fluid, this water, is not inside the cell, neither is it inside a blood vessel. So it's somewhere in between. Are they out? Is that fluid really participating in any body or cellular activity? No, that water is as good as gone. Okay. It didn't leave the body though. It's stuck somewhere in between, but since it's not inside the cell, it's not inside a blood vessel, so it's basically useless. Okay. Okay, let's go now to the different types of burns. So let's start with electrical burns. Unlike the other types, which is the thermal burn, meaning from any hot surface, um, and there's also a chemical burn, there's also a radiation burn. Electrical burns are especially devastating and complex because it does not only generate heat, but when the electrical current travels through the body, the damage is actually sustained internally. And the extent of the damage depends on how long were you exposed to the electrical current and how much voltage was involved. The skin injury, therefore, that you see in electrical injuries is just the tip of the iceberg. Usually, when we see electrical burn patients, the injury to the skin is very small, okay? But doesn't mean it's a minor injury because, again, most of the patient's injury sustained are internally sustained in the internal organs, especially the heart. So what do we expect as a complication with patients who sustained electrical injuries, including lightning strikes, cardiac arrest, okay, because they will have arrhythmias, okay, because we disrupted. These are high voltage currents. This will disrupt the electrical activity of the heart, and not to mention burn delicate tissues and organs as the electricity traveled through the body. So most burn injuries they'll have two, one entry and then one exit, meaning wherever the electricity entered their body, that's the entry wound. So that part of the body will have a burn, and there will be some exit somewhere. So there will be a second burn injury site wherein the electrical current left the body. Okay. So for me, the worst would be that the entry site would be on the left testicle, and then the exit was on the right testicle. Okay. So that would be the worst, correct? That's just an example. So here's different types of electrical injury. So it could be flash injury, conductive injury, like say, who has done this before? You were wiping something and then water fell into the electrical outlet and then you got electrocuted. You haven't done that? Okay, I did that. Um, okay, very good. Who else have good examples? Charles, how'd you burn yourself? No?
With a hookah coal.
You what?
I was
A hookah?
The coal fell on myself.
I thought hookahs are just with fire.
No, the coal. It was like
They're electric?
no, it's like charcoal. Yeah. The charcoal. It fell on me and burned.
Oh, well, was it fun though?
No, it took my skin away.
Oh no, okay. Oh, sorry. Sounded fun. And as already mentioned, it could also be lightning injuries. So when you sustain a lightning injury, you should buy a lotto ticket because you're very lucky. Okay? Not very many people get struck by lightning, just like not very many people win the lottery. So management for electrical injuries include fluid resuscitation, of course. We will calculate this under the resuscitative phase. We'll get to that shortly. And of course, the patient will be on a cardiac monitor, and we'll take care of the skin injury, but our concern really is on the patient's cardiac function. All right, let's go now to the effects of burns on each body system. You lost fluid, so what will be the response by the cardiovascular system? So we got RAS, right? Renin, angiotensin, aldosterone system, as well as the sympathetic nervous system. Okay. So here, catecholamines, that's your epinephrine and norepinephrine. So we won't repeat that. We did this already under hypovolemic shock. Okay. That's the same story. So this is what I mean by burn shock is initially a type of hypovolemic shock. But you see, burn shock it also involve vasodilation. So it's a combination really of hypovolemic as well as distributive, because what will happen initially is hypovolemic shock followed by distributive because the patient's blood vessels will become leaky and vasodilate. So you're dealing with two mechanisms of shock. So summarize system by system, you have table 57-2. But again, please, I encourage you to read the paragraphs as well. So cardiovascular, as I mentioned, there's cardiac dysrhythmias, including cardiac depression, edema, hypovolemia, including shock. Pulmonary, initially there will be vasoconstriction. But then once edema starts, then there will be bronchoconstriction. Then the GI tract, as with any other serious injury, there will be impaired motility, meaning the patient could go into ileus. Okay, there will be no peristalsis. Kidney, of course, it will shut down okay, because the patient will go into shock, therefore there will be AKI, oliguria, anuria. And finally, on the skin itself, thermoregulation is gone. The patient's at risk for infection because there's no skin protection. And then hypermetabolism, this is common in any serious injury. The patient will enter a catabolic state. So early in the therapy, because these patients go to ICU, they will be given nutrition after the first 12 hours. Okay, so we'll insert a feeding tube, start giving the patient um, nutrition, tube feeding, because they are in a hypermetabolic state. They will require 5,000 kilocalories per day or more. As I mentioned earlier, the vascular leak, the capillary leak occurs during the first 24 to 36. It can also reach up to 48 hours. So during this period, this is when the fluid is leaking out of the capillaries of the patient. The leaking is not, well, initially, like I said earlier, it will start at the site of the injury, but then later it will become systemic, meaning even the areas that were not burned will start leaking. Instead, so therefore, yes, initially the burned area will be edematous, but then over the next 24 to 36 hours, the entire body will start getting edematous as well, including the lungs. So here's the systemic response. Edema starts local first. Edema forms rapidly around the burn injury. However, over the next several hours, the edema will extend to the rest of the body, all the other body systems. So this is what I was talking about earlier. The increased capillary membrane permeability will cause the third spacing, the edema and the fluid leaking. We'll discuss the phases shortly. For patients who experience compartment syndrome, because when the skin is leathery, let's say you burn the entire arm, okay, so we call that as circumferential burn, meaning you burn the entire arm, the entire leg, the entire torso. When they become very crispy like this, like chicharron crispy, will that skin still stretch? So if the torso, for instance, was burned, the entire torso here from your chest down is burned. Now it's leathery. It's very tough. Can the patient still breathe normally? No. So what should be done? Because remember, there will be edema. How can edema occur? How can the body swell if there is leathery skin? Does that mean there will be no edema? No, edema will persist. So if there's swelling inside, but you contained it or you restricted it because of the very hard leathery skin or crispy skin, what will happen? Compartment syndrome will occur. Okay, what are the 6 P's of compartment syndrome again? Pallor, pulselessness, pressure, pain, paresthesia, or paralysis. Okay. So this is the treatment. The physician will perform an escharotomy. This is not really the same as fasciotomy. So in compartment syndrome, it was fasciotomy, correct? The doctor will cut all the way to the fascia of the muscle. This one will not really be that deep. They will just cut enough on the into the subcutaneous layer, just enough to release pressure and then restore blood flow to the distal area. Okay. Have you seen the new series, The Pit, on HBO? Yeah. The second episode, I watched the second episode. They had a very good example of escharotomy. So the ER doctor, I was actually a med student, performed an escharotomy. Okay, so they cut through the skin. A burn patient came in, and then they showed how to perform a fascia escharotomy. Okay, so they cut through the burnt skin and then release the pressure. So that's what we call escharotomy. A fasciotomy may be necessary if, let's say, after an escharotomy, the patient still did not produce any distal pulse. So the doctor may have to cut deeper, perform a fasciotomy. Initially, after the burn injury, these are the fluid and electrolyte problems that will occur because the cells, blood vessels, and other tissues were burned and destroyed. Potassium will spill into the bloodstream, causing hyperkalemia. So this could occur during the first 6 to 12 hours of the injury. However, later, once the patient enters the resuscitative phase, wherein they will receive massive amounts of IV fluids, the patient will go into hypokalemia, right? So, but they will start as hyper first and then go into hypokalemia. Sodium levels, though, will be low throughout the first 24 hours. Serum sodium levels will be low in either phase. Here's another example of fascian escharotomy. Okay, this is again necessary in order to relieve pressure and then restore blood flow. Because if you did not cut this, that patient will lose their arm or their leg or their life.
So this is done intentionally to save the patient.
Say again?
But this is done intentionally to save their limb or their.
Yes, this is a life-saving incision that is made. It's not just any incision. It has to be strategic. Okay, so it's they have rules on where to cut exactly in order to relieve pressure, and because this will become a chronic wound. Okay, so once the swelling goes down, this wound will not be stitched. Okay, so it'll be left open and it will be left to heal from the inside out. Right, but again, it is necessary though in order to save the arm or the leg. Okay, so or to save the life if it is done on the torso, because you can also do cuts on the torso to expand the chest so the patient has adequate ventilation. You understand? Any questions on escharotomy? Wound care. But of course, in the first place, for you to initiate this, meaning what would make you call the doctor to perform this one? The 6 Ps. Okay, so if you see signs of compartment syndrome, because the compartment syndrome here is caused by not a cast, not a dressing, but the skin, the burnt skin, because it became very hard. And remember, what is going on after the burn injury? There will be swelling and edema, right? That's the natural response because, again, the capillaries become very leaky and all the blood vessels dilate, and then it will cause severe swelling. And it can't swell unless you release the skin because the skin is very tight. So if you have a very tight skin, very leathery, hard, but there's swelling underneath because the swelling will not stop just because the skin is tight. So you have to release the pressure. So they make a strategic cut, releasing pressure, blood flow will be restored. Any other question? Alrighty. Pulmonary, so like I said, acute lung injury will occur here, but we will discuss ALI under Module 8. Upper airway injuries. So how do we know they have upper airway injuries? So we look in the mouth. So if the tongue was burned, there's any soot, black soot in the mucous membranes, okay, or maybe there's the sputum looks black, okay, or brown. It definitely there was some burn injury, right? Or you can clearly see the mucous membranes are all swollen, and you can't look down the throat. It's all swollen. What would be the lung sounds? Can you hear wheezing? Yes, you hear wheezing. Wheezing is actually better than no sounds, correct? So if you hear wheezing and then the next time you listen, let's say 5-10 minutes later, you don't hear any sounds anymore. What's happening? The airway is closing. Okay, so that's what I mean by bad sounds or abnormal lung sounds. It's better than no sounds. Okay. However, like I said, the protocol is when we suspect airway injury, even if the patient's airway is still open, we will intubate this patient because yes, it's open now, which is good. Later, it won't be anymore. The swelling will get worse. Okay, it will not get better. So the first 24 to 36 hours, will the patient get better? No, this patient will get worse over those first 36 hours. So you expect that worsening, so you intubate the patient so that we won't have any problems, like we don't have to place a trach. Okay, so that way the patient already has an endotracheal tube, and that will be way better. If necessary, the patient will undergo a bronchoscopy. Let's say there's really several burnt tissue there. The doctor will have to perform an emergency bronchoscopy, meaning put the scope down the patient's throat and then clear any debris. Maybe there's some, burnt particles there that's blocking the airway, so they'll have to mechanically remove that using a bronchoscopy procedure. There's also carbon monoxide poisoning. What is carbon monoxide? It's a tasteless, odorless gas. Okay, so what makes this when there is? So why is it CO and not CO2? We're missing an oxygen molecule, correct? Meaning this will be produced when the fire, when you burn something in wherein there's not enough oxygen. Okay, so let's say what would be somewhere where you burn something and you don't have enough oxygen? A warehouse, anything enclosed, okay, a small apartment, for instance, okay, a factory, okay, with poor ventilation, okay, meaning enclosed areas, the windows are closed, no air conditioning. So there's burning. However, because you don't have enough oxygen molecules, so now you produce CO, okay, and which is just as deadly as being burned, because this one, although yeah, you did not inhale any flames, but there's no perfusion because you don't have enough oxygen. Because the funny thing is, our hemoglobin carries oxygen, correct? There are 4 binding sites. One hemoglobin molecule has 4 oxygen binding sites, meaning one hemoglobin will carry 4 molecules of oxygen. However, if you give the body a choice between CO and O2, it will rather stick with CO. Meaning, so now if your hemoglobin are now carrying CO instead of O2, what will happen to you? You'll die. No oxygen, you're dead. Because this is CO and not CO2, the patient will not look cyanotic. The patient will just be unconscious, and the only way you can tell that they're having carbon monoxide poisoning is the color of the mucous membrane. It will be dark cherry red. Okay, so that's the only way. Of course, we can know also with drawing blood. We'll draw blood and then calculate the carboxyhemoglobin. This one. So to diagnose CO poisoning, officially, we need carboxyhemoglobin. But until then, you can also tell by the color of the mucous membrane. If it's cherry red, you know what cherry red like? It's a different red, yeah? Not like this red. Cherry is like dark, yeah? Dark kind of purplish. Okay, so if it's cherry red, then they have carbon monoxide poisoning. The treatment is 100% oxygen. So you put them on oxygen for 1 to 2 days, that should improve. Meaning you're giving the patient a choice now, meaning the red blood cells a choice. Because again, as long as there's carbon monoxide in the bloodstream, what will the red blood cells do? They will take the carbon monoxide. Okay, so Again, if there's a choice between oxygen and CO, what will the RBC take? They'll take CO, okay? Because they can't tell whether that's good or bad or not. They just know, oh, it's easier to carry. Okay, so CO meaning hemoglobin has a higher affinity. What is affinity? Like desire or favor, right? So it has a higher affinity for carbon monoxide over oxygen. And what's the treatment for CO poisoning? Oxygen, 100% oxygen. Kidneys, we already know RAS will be activated, so there'll be oliguria. Obviously, the skin is gone, so patients at risk for infections. And no thermoregulation, so this patient will be very prone to hypothermia. And GI, like I said, will be. Can they have ulcers also here? Yes, they will develop stress ulcers. Okay, so what do we give them to prevent stress ulcers? PPIs, very good. And once there's ulcers, then there'll be GI bleeding now. Okay, so PPIs are very important.
So we learned from the previous lectures that the peptic ulcers are not caused by stress anymore.
Yeah, I didn't call it peptic ulcer. I call them stress ulcers.
Wait. Yeah, there's stress ulcers, right?
Yeah.
Yeah, so
That's different from
Yeah.
peptic ulcers.
so in this
Because
case,
peptic ulcers are caused by NSAIDs and H. pylori, right?
So-
Yeah. So this one, stress ulcers are caused by stress, obviously.
ulcers,
Yeah.
okay, right.
In ICU patients, they call them Curling's ulcer. But really, the term, a different term is used rather than peptic ulcer because the cause is different. Does that make sense? But if you if you do an endoscopy and look at the ulcer, they look the same. Peptic ulcer will look the same as a stress ulcer. But we have to distinguish because the treatment is different. Meaning, are you going to treat a stress ulcer with antibiotics and PPI? No, just PPI only. Does that make sense? Okay. Be careful about this term, ACS. This is not acute coronary syndrome, okay? This is acute, this is abdominal compartment syndrome. Okay, this is different. The ACS they mentioned here, abdominal compartment syndrome. Right? This is different. Okay, management. So there are phases. There's actually a pre-hospital phase because the emergent phase will be when the patient is in the hospital. So let's start with on the scene. So let's say let's burn Francois. Okay, Francois was cooking turkey for the first time in a big pot of peanut oil. So he dip the turkey there, but then the string broke. The 5-pound turkey fell into the hot oil and then splashed oil all over him. And he was only in shorts. Okay. I don't know what he's doing in shorts. Thanksgiving is cold, but he was wearing shorts. Okay. So he got splashed. Okay. So the first step at the scene, are the paramedics already there? No, we still have to call them. Okay. So somebody called, and then in the meantime, he's hysterical, right? Crying like a girl. And then somebody will help him. So what will we do as a first aid?
What are you?
Okay, cold, douse him with even just tap water, okay? Because it's fall anyway, so the tap water will be cool, right? We don't really use ice cold because because ice cold will cause more vasoconstriction. There's already poor circulation, so no ice water, just cool water. So cool water, which is common in the fall, we have plenty of cool water. So douse him with cool water. If you have a hose him down, then cover him with wet, wet towels. Okay, so to keep him cool because we need to cool the injury. Okay. Um, When available, of course, airway is our priority, right? But do we have oxygen around Thanksgiving? Not really. So, but if you have it, yeah, maybe the neighbor is on oxygen. So give Francois some oxygen. And once there'll be a chart for first aid. It'll be later, right here. So chart 57-4. Once the paramedics come, we will put in, give him oxygen and then put in as many large bore IVs as we can. But most likely, once the swelling starts, is it easy to start an IV site on Francois now? It'd be quite difficult, right? So as much as possible, as early as possible, we should already have started an IV. But if it's not possible, then we'll have to wait until he gets to the ER and then we'll put in a central line, okay? Because he needs fluids. So here is our rule, A, B, C, D, E. Okay, you learned this in BLS, right? Okay. I'll skip the phases first because these are large paragraphs. Here, so here's the first aid. So at the scene, chart 57-4, this is, use common sense when you apply this, okay? So when I give you a scenario, please use common sense. So when we say ABC, are you going to, don't tell me you're going to put the oxygen on while Francois is on fire.
No.
Okay, you have to extinguish the flames first. So patient's on fire, then put it out. Once, of course, if the patient's no longer on fire, then you can apply oxygen, yeah? So we know stop, drop, and roll, correct? But is the patient conscious about this?
Oh.
No, usually they're in panic, so they'll be running around instead, right? Okay, so put them on the ground. Okay, if we need to force them down, we'll have to do that. Again, douse the flames, extinguish it with these, anything you can find to deprive the fire of oxygen, yeah? That's the purpose. So no oxygen, no fire, meaning no fuel. Okay, and then if the patient is conscious, you ask them to sit, no, stop, sit, and pat, right? So extinguish the fire. Next is cool the burn. We already did that. We doused him with water or put, wet blankets on him. Okay, again, cool, okay? Not ice cold. Then remove restrictive objects. So if he has a watch or a ring, for instance, we may not be able to remove them because remember, the patient will get swollen over the next 24 to 36 hours. So remove them. So if he's wearing a the really tight boxer pants he had, it was spandex. Okay, so we have to cut them loose. Okay. Don't worry, you won't be naked. We'll cover you with a gown. Okay, you'll be okay. We'll keep you modest. And then finally cover the wound. Now, what we cover the wound is nothing that will stick. So can we use gauze? Gauze will stick. So what can we use? Anything non-adherent, okay? So something moist, for instance, or if you have to use gauze, then it has to be a non-woven type. Okay, we have gauze that is non-stick. ABD, what do you mean? Well, it has to be something clean, okay? Like, dressing grade, okay? Again, cover him because there's no more skin, so thermoregulation problems, okay? He lose heat, he lose fluids. Okay, and then, okay, for chemicals, my take about this, because this one says, they say irrigate, right? But unless you know the chemical that was causing the burn, it's probably best not to, because what could happen? So some chemicals react with other substances, right? Like some chemicals may have a different effect if you mix it with water. Okay. So unless you know and are confident about the chemical that caused the burn, that it's safe to be irrigated with water, then yeah, do so. But if you're not sure what it is, probably not. Okay. What we can do instead is if we can remove as much of the chemical off the patient, especially if it's a dry powder chemical, then that's good. We can brush it off, right? And if the clothing has been doused with chemicals, what will we do? Remove the non-adherent clothing. Of course, you're not going to rip it off if it's already stuck to the skin. So if there's any clothing still not stuck to him, you can safely remove, then remove it because we may not be able to remove them later. Okay, because again, plus the chemical is on the clothing. So as long as the clothing is on the patient, then it will continue to burn the patient. Yeah. So it's best to remove them. Yeah, please read these very carefully, okay, in detail. I won't read them for you. As already mentioned, airway is best. Priority. We keep the patient NPO. Okay, it's not really a good idea to feed a patient after a burn injury because they'll have, the effects, right? On the GI tract, they'll start vomiting because there's no peristalsis. All right, let's go now to the medical management. So after we've taken care of the airway and breathing, let's go now to the circulation. So let's go to the first, so we are now in the resuscitative phase. So this is the first phase of the burn injury. So after airway breathing, we will now focus on circulation. So that's why this first phase is called the emergent or resuscitative phase. Our goal here, besides airway and breathing, is to restore circulation. So we will be giving fluids, large amounts of fluids to the patient. That's why we need large bore IVs, or if available, we should have a central line. Okay. So the fluid use is LR. This is preferred, but if you don't have LR, then saline. But LR is preferred. The formula is this one. So this formula is called the Parkland formula, also called the Baxter formula. So Parkland, Baxter is the same. Parkland? Parkland, like the shooting victim in Florida? No? Parkland? Parkland, Florida? Parkland. Or Baxter, Baxter, right? Our IV pumps, IV fluids, Baxter. Okay. Don't use the 2 because we're doing adults. So we're using 4. So Parkland formula is 4 mLs per kilogram per TBSA. So let's do an example. So let's say Francois was covered in boiling peanut oil from his face down to his feet. The entire front of his body. His backside was clean. Backside, no burns at all. So calculate his TBSA. So his face would be 4.5. And his front torso will be 18. And his left arm will be 9. 9, right? No. Each arm is 9. 4.5. Okay, 4.5. So 4.5 for the left arm. And then another 4.5 for the right arm. And then the right leg will be 9, right? 9 plus 9 again for the left leg. I lost count. Is it 49.5? So 4.5 for the face, and then 18 for the trunk, 4.5 and 4.5 for each arm. So that's 9. And then 18 for both sides of the leg. And then his penis was also burned. Okay. plus 1. 40.5. Yeah, I got 18 already. How much you got? It's 40.5, yeah? You got 40.5? Yeah. So it's 40.5. So times 4. And let's say, how much do you weigh in kilograms, Francois?
160.
You
80?
150.
No, a kilogram. So about 80?
80.
Let's say 80. Okay, so let's say 80 kilograms. So we have 12,960 ml. So 12,960 will be his total fluid for the first 24 hours. Okay. Now, timing is crucial according to the textbook. So how do we, or when do we start counting the 24 hours? From when he arrived in the ER? When did he start losing fluids? When he got to the ER?
No, when the what EMS when he started burning.
So when do we count the 24 hours? From the time he got burned. Because that's when he started losing fluids. Okay? He didn't start losing fluids when the ambulance came, right? No, he was losing fluids way before then. Do you understand? Okay. So the timing will be counted from whenever he spilled the oil. When the oil came on his whole body, that's when he started losing fluid. So now somebody should have taken note of that. Oh, turkey burn at 2:25. All right, and then somebody called 911. They got here maybe 15 minutes. Okay, so in meantime we were washing him down. He's still crying, right? So how are we gonna give the 12,960? We're gonna divide this by 2 because here it says. So here, the starting point is the time of the injury, not the time of arrival to the facility. Understand? Okay, so we're gonna get the total calculated amount, which is 12,960. Half of that will be given during the first 8 hours. Okay, so let's say the EMTs, they tried, they could not get IV access because he's already very swollen, plus the area skin very burned. So they had to take him to the ER. He got there at 2:55. He lost 30 minutes. So does he still have 8 hours? No. So what will we do with the 12,960 divided by 2, right? Because we're gonna give half of it over the first 8 hours. So divided by 2. So we need to give him 6,480 during the first 8 hours. But do we have 8 hours? No, we lost 30 minutes. So 30 minutes later, he is at the ER. The doctor successfully put in a central line. So now we divide this by how much time do we have? 7.5 divided by 7.5 hours. So on the pump, you will enter 864 mLs per hour. Do you understand? Okay. So 8 hours later, oh no, so 7.5 hours later, what do we do? So the other half, what was the number again? 6,480. So the other 6,480 will be divided over 16 hours. So another 6,480 of LR will be divided by 16. So initially 864 and then you drop it to 405 mLs per hour. Is this accurate? So, right? So. Because do we actually know his actual weight? Did we weigh him before he burned the turkey? No. We estimated his weight. Yeah. So yeah, he's about, we said he's about, because when you weigh him, let's say we were able to weigh him in the ER. Is that weight accurate? Because remember, he started third spacing, correct? The fluid started coming out, so he's now edematous. The fluid left his cells, left his blood vessels, but did not leave his body, correct? It's somewhere in between. So is it still part of the weight? Yes. Is that weight therefore accurate? It's not. So therefore, since the weight is approximate, is this fluid that we calculated really enough? Is this really accurate? This is just an estimate. Okay, that's the reason, because he started getting edematous for that just few minutes. He started having edema already. So therefore, his weight is not accurate. So how do we know that we're actually giving him enough fluids especially during the first 8 hours? Urine output. We will have to put in a Foley. So we'll take his edematous penis, put in a Foley in it, and then measure hourly urine output. So if he's making urine of 1 ml or 0.5 mLs per kilogram or 1 ml per kilogram per hour, then he's getting enough fluids. So what if he's only making 0.3 ml per kilogram per hour? What will we do with the fluids? We'll have to increase the fluids. Make sense? You understand now the treatment? Okay. Any questions on the fluid resuscitation? Because these are large amounts of fluid, right? What if we give too much? Okay, so how do we know we've given too much? Okay, his urine output also, plus also his, what will be faster? His lung sounds. Okay, so if we drowned him with too much fluid, let's say somebody put the wrong decimal, for instance, or added a wrong extra zero, now we messed up. Okay, so now he could die of fluid overload. Okay, but so either fluid overload or maybe not enough, right? Because again, was the weight accurate? No, because we weren't planning on burning him today, so we didn't weigh him today. Yeah, so next time you cook turkey, weigh yourself first. Okay, so establish that weight. That way, when you get burned, now we have an accurate weight to give you IV fluids. Any questions? Okay, so we'll continue next week.